I wanted to talk about is about dengue in Hawaii. I don't know if you have seen this in the news. So there's been a new cluster of locally acquired cases of dengue, and it's on the Hawaii island, which they have not had locally acquired cases there before. In the past, there was a case, dengue outbreak on Oahu in 2011, and so there, as of yesterday, there were 65 cases. Um, the majority were in local residents, but there were 10 in visitors and 17 were in children. But they're expecting this outbreak to actually end pretty soon because they're having their dry season coming up here, which is different than other parts of like the Caribbean where they just kind of they have wet weather all the time. So I don't think it's going to go much farther than that. But it's just kind of interesting. The other thing that's kind of been in the news recently, um, I've kind of been seeing it around Facebook and other places, is about the Men Afrivac vaccine that came out recently. So the story of this is interesting. They in sub-Saharan Africa, every couple of years there's a large meningitis outbreak, and it's usually meningococcus group A, which is the has more outbreak potential than other types of meningococcal disease that we see here in the United States or in other developed countries. And in around 1996, 1997, there was a huge outbreak with 250,000 cases across sub-Saharan Africa. And around that time, African leaders actually went to kind of bigger World Health, like the WHO and other organizations, saying, we need to really work on this because it's a huge amount of debility and morbidity and mortality in sub-Saharan Africa. And so they actually got together and created a vaccine that has been shown to be 94% efficacious. And the vaccine actually contains group A meningococcus and tetanus toxoid, which both I think are very kind of neglected tropical diseases. And so it's kind of fantastic. They've vaccinated 220 million people at this point, in 16 out of 26 countries. And they did do kind of an efficacy study in Chad, I think around 2007. And essentially, in the vaccinated population, there was no meningococcus, essentially. It was, the 94%. But in the non-vaccinated population, they did have an outbreak. And so the goal, obviously, is that to vaccinate as many people as possible and with the hope that outbreaks will essentially disappear. And they've pretty much shown that in areas that have been vaccinated, they have not seen outbreaks. So I think it's a huge public health victory that we're seeing in Africa, where meningococcal disease may become essentially eradicated in this part of the world. It's pretty fabulous. So I'm going to go through a case that actually our third speaker, Dr. Balnick. Sorry, I don't know if I said your name right. Yeah, I also went to Eldoret, Kenya when I was in medical school, and so we kind of discussed that this is a scenario that we saw multiple times, and actually is very topical in terms of mental health. So I wanted to kind of present this case and then kind of talk about some basics about it, especially from a critical care background. So we'll kind of go through it together. So this is a 35-year-old male who was just found down, essentially, and brought in by his family. And we don't really have any other history. So on physical exam, he is hypotensive and bradycardic with tachypnea and hypoxia, and is a bit hypothermic. And so his GCS is 9, and he's essentially altered, incoherent, and in respiratory distress and covered in vomit. And on HENT has meiosis and drooling, and as I mentioned before, he's tachypnic with wheezing and crackles in the bases, diminished lung sounds, and shallow breathing. So he has bradycardia, but it is regular with weak pulses. And then GI, he has hyperactive bowel sounds, fecal incontinence, but his abdomen is soft and non-tender. And he just is diffusely weak, but he is moving all extremities, and he has no edema. So here in this part of Africa, it generally takes 24 hours to get labs. So what would you do first, and what would kind of be at the things at the top of your differential? I was hoping to have some audience or participation. I'll try to repeat what you say so that we can actually record it. Sorry, what'd you say? Oh, so cholinergic syndrome is what Matt said. And then kind of what would that be from? Pesticide exposure. Yep, great. I think that definitely needs to be at the top of the differential. Mm-hmm. Yeah.
Making sure that you're not missing an infection.
Yeah, so sepsis definitely, or like meningitis, or meningococcal sepsis in this part of the world. I think similarly malaria, also cerebral malaria. So in parts of Kenya, especially in the higher altitude, it's not endemic there. So in Eldoret, Kenya, we would have many people who would go to like Lake Victoria, where it's highly endemic, and actually come even at 35 years old. Everyone's like, oh well, in Africa people don't get cerebral malaria at that age, but in that part of Africa they do, because they have not been repeatedly exposed when they were young, and they would actually have cerebral malaria at that age. So we did see that sometimes in that part of the country too, and they can have bradycardia and respiratory distress and many of the other symptoms that run this patient. Okay. So I'm gonna keep going for time's sake. So essentially it is organophosphate poisoning. I think it's a very underrepresented disease in terms of the discussion in global health, and very neglected. Kind of as a reminder, so as Matt kind of mentioned, it is a cholinergic process with excess acetylcholine and kind of increased parasympathetic activation kind of throughout. And so people kind of present with what you kind of see in this patient. So they can have meiosis, tachypnea, kind of from more respiratory secretions. And they often are covered in having urinary incontinence or covered in stool, and often coming in altered or actually in coma. So there are 3 million pesticide poisonings worldwide per year, actually, and about 2 million of them are deliberate. And that from that 3 million, about 250,000 are actually fatal, and it accounts for about 30% of suicides overall worldwide, including the developed world and the tropical areas. And it can be organophosphate poisoning or carbamate poisoning. In this part of Africa, I think organophosphate poisoning is much more common. So people will present with ocular symptoms like blurred vision, meiosis, increased lacrimation and diaphoresis, respiratory symptoms. So it's usually from bronchospasm or from increased bronchial secretions. So rhinorrhea, bronchorrhea, bronchospasm, and then severe respiratory distress. They have bradycardia and hypotension, nausea, vomiting, diarrhea, abdominal pain, and hypersalivation are very common, and then urinary incontinence. So kind of reminder from medical school, there's some mnemonics that people use for cholinergic syndromes, I think, that are helpful. I don't know, some people find them helpful, some people don't. It's just a good reminder. I've seen these two commonly used by medical students in the past. And so essentially it's from an overstimulation of nicotinic and muscarinic receptors in the CNS. So they can have confusion, agitation, coma, and respiratory failure. And then overstimulation of nicotinic receptors at the NM junction. So muscle weakness, paralysis, and fasciculations. So in the developed world, is usually non-toxic drugs, actually. So the case fatality is only 0.5%. I mean, even though we talk a lot about like Tylenol overdoses and other things, it's very rare that people coming in with overdoses actually overdose to the point of having a lot of morbidity. Or they may be in the hospital for a short period of time and then be able to go home, or hopefully to like a psychiatric kind of facility. Or a lot of times that people will take a lot less and a lot less toxic doses with that as well, or less toxic doses and less toxic medications. But in other parts of the world, they're readily available, and most common are agricultural pesticides. And so the case fatality is much higher for that reason. And this is especially common in rural areas. So in some parts of the world, greater than 90 or even as high as 90% or 60 or even up to 90% of suicide attempts are actually from pesticide poisoning. And what, I was talking about in Kenya, my own experience, they did look at a case series in 19 hospitals in 2012, and about 43% of poisonings were due to pesticides, and about 57% were organophosphate, and about 44% were deliberate, as far as they knew. And especially that's most common in kind of the high-risk 21 to 30-year-old population, in which, if you think about how much, like the potential for, contribution to society in terms of work and their family, that's a huge burden, actually. So in terms of ways that they've attempted to reduce this, so in some parts, the best examples actually have been in Sri Lanka. So Sri Lanka has a very high rate of pesticide poisoning. So here, 71%. So they have actually attempted to decrease that. So they've restricted the use of toxic pesticides and use safe storage pesticides in rural community. And they've actually improved the quality of care and accessibility for patients from this poisoning. And so they also created tools to attempt to recognize it sooner. And so they are kind of still looking at that, but they have demonstrated that they've been able to significantly reduce the amount of deaths from pesticide and from organophosphate significantly. And they actually have also improved kind of like their mental health facilities for these kinds of patients. So I think the main things to take away in terms of management of organophosphate poisoning, so decontamination and protection for your team are the first thing. So you need to make sure that your own team is protected because it's actually absorbed through the skin. So if healthcare providers or family members actually touch the person's skin, they can actually become poisoned themselves. So it needs to be recognized quickly and also decontaminated quickly because of that risk. And so after that decontamination, then you need to protect your own team, and then you can perform, ABCs or, who you taught to, CAB, so circulation, airway, breathing. And then you can give atropine in IV doses every 3 to 5 minutes to improve the heart rate. Because it's a competitive inhibitor of cholinergic receptors. But if you don't have atropine, in some parts of the world, they also use glycopyrrolate or diphenhydramine. And then you can use palidoxime. So or people call it 2-PAM. So it's 1 to 2 grams every 8 hours. And so it reactivates the acetylcholinesterase by binding the organophosphate, actually, and actually reverses paralysis. And the last thing you can do is, if you need to, you can use magnesium, which is a competitive inhibitor to acetylcholine. And so I have a picture from Sri Lanka, actually, and I want to kind of talk about what they're doing right and what they're doing wrong in this case, if people wanted to kind of talk about it a little bit. Yeah, so they're not wearing gloves, so I think that's really important. It's unclear, actually, in this picture if the patient was contaminated or not. I wonder if he was because of the blue bag. But I still do think it's very worrisome that the team is not wearing gloves or protective equipment as they're taking care of this patient. Yeah, so they're working on his airway, right? And he has IV access in his right forearm. So I'm assuming they're taking care of circulation. So I think the thing that I think is most important with this is that I think that they're demonstrating in this picture that they decontaminated him outdoors before bringing him to the hospital, and then after that they're dealing with kind of the basics of resuscitation, and then their plan is to take him into the hospital to kind of manage it further. And then so these are my references. Does anybody have any questions? Okay, awesome. I think we'll keep going.
One question.
Yeah, sure.
Roughly, do you know, in Minnesota, what kind of poisoning rate or cases that we get here?
I mean, so I don't know if there are actual numbers, and I don't know if our psychiatry colleagues can help us with that. I do know that we have seen cases in some of our refugee populations. I've heard of cases kind of more anecdotally within Hmong populations, and then also within some of our newer Burmese populations. I think that's kind of reflective of like where they came from, and also the accessibility to pesticides that are not organophosphates just are not used as readily in the United States. They're restricted, and so we just don't see it as much. But those kinds of pesticides are available kind of in the gray market, and so I have heard of cases. I also did see some cases in Latin America when I was a medical student. And so I'm sure in the southern United States it's a lot more common than we see here. Yeah. Unfortunately, I don't know. Yeah. So he asked if there are any brands of organophosphate pesticides that we should be aware of. I do know that they're highly restricted in the United States and really are not used in practice very much.
You talked about suicide, 30% losing that.
Mm-hmm.
Could you elaborate on that? Is that in Africa, Asia, combination?
Oh, so what I was kind of saying is this 30% is kind of worldwide if you look at all suicides across all countries. And then in terms of poisonings in those parts of the world, the rates are much higher. The problem is, I did try to figure out, I did kind of look at that, how many of these within the rural areas were deliberate, but I think about
Pleasure to be here. I've heard about this seminar series the last couple of years since I moved here from Massachusetts, and I have not attended once. And so thank you, Beth, for inviting me and Dr. Bannock to present tonight. And thank you to the Planning Committee for putting global mental health on the agenda for this year, because it's just such an important topic. From the numbers of you here, it's really great to see what an interest there is. I'm just curious who's in the room, because it is my first time. How many are practicing clinicians, medical students, nursing training? Okay, super. And practicing clinicians in mental health? Okay, great. What about public health or policy folks? Okay, or people who are doing both? Okay, great. Okay, good. Thank you. That just kind of helps me get a sense. So just as we go along today, I just want to encourage you to kind of reflect on your own clinical or research or policy sort of work that you're doing, and just it'll be great to have a discussion. I think I'm going to speak for about 30 minutes. I'm hoping is that going to work with time, and then some time for 25, 30, and then some time for discussion, and then Dr. Bannock is going to speak as well. So my part of the talk is global mental health in our backyards, and then Dr. Bannock is going to go on to talk about abroad. I have nothing to disclose, and this is some of what we're going to cover. Describing global mental health and its key challenges and opportunities, a really huge topic. I am focusing on the backyards part, but to do that, I wanted to give some context of sort of what's going on globally, because fundamentally here in the Twin Cities, we are a part of the globe, and so it's important to have sort of the context. And then Dr. Bannock is going to dive into that, the abroad part even more. I'm going to talk about global disease burden of mental and behavioral disorders, and then talk about the issues being faced by folks here in the Twin Cities, and in particular, the immigrant refugee population. I'm going to skip over this a little bit just for time, but just wanted to just mention here, these are just some pictures from, it feels like another lifetime when I was in the Peace Corps in Cameroon, but that sort of, there have just been so many salient experiences. If I were to look back at my training, where I've had the opportunity, and I've really tried to seek out sort of getting experiences in multicultural clinical settings that really have brought me, as I was finishing residency in Massachusetts, sort of in thinking about places to go with our little family. Minneapolis came on the radar, and part of what really drew me to Minneapolis, in addition to having some family contacts here, was this just shows just some of the demographics, which I'm sure most of you are familiar with, just so that the bars would make a statement. Whites are not on this graph, But in the U.S., whites make up about 77% of the population, and in Minnesota, as a state, it's about 86%. But interestingly, in Minneapolis, whites make up about 63%, and then you have also large numbers of folks from minority groups. And so that was really interesting to me. There's a really large foreign-born population here, which was interesting, and in particular, the refugee population. This is a slide from the Department of Public Health Refugee Health Program that maybe some of you have seen, and it shows the wave of immigrants that have been arriving since 1979. And the yellow represents the Southeast Asian refugees coming from Cambodia, Vietnam, and the Hmong. And you can see that kind of started to peter down in the mid-90s when the purple bars represent folks from sub-Saharan Africa, largely Somalis. And what I want to just point out here is that in 1991 is when the war erupted, the civil war erupted in Somalia. And you can see the delay, or just the time that passed until folks really started arriving in, say, 1999 when you first started. So it's just important to remember when we're seeing someone here from Somalia that there was probably somewhere like a 7 to 9 plus period of time where they were living in displacement, refugee camp, harsh conditions, insecurity related to food, housing, disrupted relationships. And that's just something that I always keep in mind. Only 1% of refugees in camps, and right now I think we have 19.5 million refugees in the world, 1% ever get resettled. So, I mean, whenever I'm sitting with someone from that background, it's just what a chance, that they are here. So the other thing that happened when I visited Minneapolis was I sort of stumbled upon this place, which I had heard wonderful things about, and had a great meeting. And this is just a little bit about Kook, where I have been working for 3 years. And many of you may know that Kook is a federally qualified healthcare center here in Minneapolis. We're part of the university. We are the university. We have primary care, mental health care, dental, legal services, and advocacy, all co-located in the same place. So case management, rehabilitative services, care coordination, therapy. So it's a really wonderful place to serve this population where the needs are very complex, and we can really try to meet them. We're a major training site for the university, and the demographics are very diverse. We have about 18 to 20% Somalis that we see, other Africans 17%. The numbers of Southeast Asians have decreased over time. There were much larger, that was a larger population in the 80s and 90s and 2000s. So I was very excited when I got there to have a chance to explore and dive into the work. So just to back up a little bit now about mental health and why it's important. So I'm sure many of you are aware that the global burden of disease due to mental and behavioral disorders is high and has a huge impact on society. So just wanted to dive into that a little bit. Global mental health is part of this large health transition that's happening right now in the world from communicable to non-communicable diseases. So left bar represents DALYs in 1990, which are disability adjusted life years. I'll get into that a little bit more in a minute. And the red bar represents 2010, and you can just see there's the shift. And when we look at DALYs, it's a metric reflecting the contribution of a disease to disability. So if a life expectancy in a particular region is 60 and someone develops a severe mental disorder at age 25, that's 35 years of disability that person is living with. So this is a WHO slide showing burden of disease by DALYs in 2004 and the projection for 2030, and you see unipolar depressive disorders moving up to number 1 in terms of a cause of burden of disease throughout the world. There's also this really robust literature describing an intimate relationship between physical health problems, and mental health problems. So this idea of no health without mental health is really caught on. Suicide is a major problem in the world. Among injury deaths, suicide accounts for 17% of deaths. And then this slide, this is not one of those images you're supposed to relax your eyes and an image is going to pop out at you. This is I'm going to walk you through it because this is a really important slide. This is also looking at DALYs by age, sex, and cause in 2010. So left is males and right is females. And y-axis is percentage of DALYs, and then X is across the lifespan. So babies to 80 years old. And this middle part of the graph is preteens, teenage years, and young adulthood. So the yellow represents diarrheal diseases, infectious diseases, HIV. There's a big swath of green in there that's cardiovascular diseases. So I want to bring your attention to the red. I'm sorry, I do have a clicker, don't I? Yeah. This right here, which represents mental and behavioral disorders. And what's really important here to know is the percentage of DALYs, but also when in life mental and behavioral disorders hit populations. And it's in this really important critical development stage in the teenage and young adult years. So there's high prevalence, there's early onset, and you have this chronic relapsing condition that continues to come up. So that has a really high impact on disability. It impacts young people from achieving their full potential, and it creates this very significant interaction between the social determinants of health, social factors, and mental health. This just sort of talks about, and sorry, it came out kind of fuzzy, but just the different mental disorders that are found throughout the world, and depressive disorders being a large chunk of that. Anxiety, substance abuse is a huge component of this. And schizophrenia, interestingly, the prevalence of schizophrenia worldwide is 1%, but it amounts to 9% of the DALYs because of how severe of a illness it is. So the other thing here is that there's this really important reciprocal relationship between mental health and poverty. And so just thinking about what we just saw on that slide of when mental illnesses come on. So as this gets dissected more in the research, it yields interventions that are really kind of putting an emphasis on integrating mental health into broader healthcare delivery, and then coupling that with programs that are aiming at social inclusion, economic empowerment, education, because of this interaction between mental health and these other social issues, it's important that the interventions are also working at that level. So that's why when I got to COOC, I was really excited, because that's precisely sort of how the COOC clinic model is designed to be able to help people at all these levels. And there's other folks in the Twin Cities that are doing this as well. The next piece is that global mental health is a human rights and equity crisis. I think most of us know that there are high rates of mental illness in prisons. 1 in 3 homeless individuals have a severe mental illness. And this is something that you see in other parts of the world too. Just a lot of times there's ways that different cultures may hang on to and support people who are dealing with severe mental illness. And these are just some images of sort of how folks with severe mental illness are often managed in places where there's just no access to treatment. There's a large article about shackling and chains, that was in the New York Times in October. And I saw this, I'm sure many of you who have worked abroad see this in areas, low and middle income countries where there just is no access to evidence-based psychiatric care, that a lot of times people are in chains. And it's a real, it's sort of one of those images that really people see, and it galvanizes sort of advocacy and energy to pull resources into addressing this issue. Did I skip one? I just talked about the high unmet needs. Okay, and then just that mental and behavioral disorders are, you know, a lot of times I think we think about the diagnosis like as if it's a thing, but just to remember these are embodied and felt experiences that people have, and that these are experienced in a context of culture, in a context of community, in the context of family. So this is usually sort of the image of, you know, brain disorders, mental disorders that we might see, and there's a problem with this in that most people don't identify as being disconnected from their bodies. So, you know, there's the brain, the mind, and there's obviously the body. And in many parts of the world, a sense of identity is really more connected with a collective, a family, being a member of a community, perhaps a cosmos. So this can have real implications on treatment, too, as we're approaching that. Okay, so diving into the Twin Cities. Can you remind me what time? Because we started 10 more minutes? Okay. So this just kind of covers some of the problems that that people come to us with that are common and sometimes need to be normalized and are part of a normal sort of spectrum of distress, and sometimes are really more severe and really impacting functioning. So fears around leaving one's house, avoiding situations that remind them of the past, thinking too much, haunting memories, nightmares, lack of sleep, that sadness, which many people don't necessarily understand what the word depression means, and so kind of really talking about sadness or loss sometimes is something that can be identified with more. There's also this, you know, presentations that are more anger, agitation, racing thoughts, psychosis. Jerry Kroll at our clinic, who's our senior psychiatrist, did a really interesting study on psychosis in young Somali men. In our clinic had sort of looked back retrospectively and found that of the Somali men seeking treatment at our clinic, 50% were under 30 years old. These were patients between 2007 and 2009. And of those, 80% had psychosis. And this was versus 14% in an age-matched non-Somali control group. So 80% with psychosis. And so got really curious about this, you know, what's going on. And so it's not entirely clear, but probably some combination of the psychological trauma of war, early malnutrition, head injury, excess cot use, which is an amphetamine-like leaf that's chewed, that a lot of times is used to cope with symptoms of mental illness. So that's a presentation that we see a lot. Substance abuse, somatization, and so this is where integration is so important with primary care, where people are, I mean, there's a lot of reasons it's important, but this is one of them. And there have been some studies, interestingly, that have looked to see if you just compare people responding on a questionnaire to sort of DSM-5 PTSD symptoms, and then also sort of ask them if they have had body pains, headaches, dizziness, or appetite change, that actually these questions can be as predictive as to whether or not someone has PTSD as actually asking them. In different cultural groups, it can be as predictive, which is There's a lot of factors which impact whether people will seek out Western mental health care. So religious and cultural beliefs and customs. For a lot of people, there's no sense of there being, these are not problems of what is mental health exactly. The types of problems that they might be experiencing are problems, religious problems, spiritual problems that they may seek out their traditional healers, which is very, very common. Autonomy versus interdependence with family and community. There's a lot of fears: fear of hospitalization, of commitment, fear of deportation, confidentiality fears. So some of these are small, close-knit communities, and there can be a lot of fear around information getting out because of stigma. Issues with gender roles. I talked about somatization. And then often, something that I didn't say in the last slide was needing practical help. That is often the thing that brings people in, is needing some practical help, like needing a transportation form signed, needing some general assistance, needing help with housing, help with citizenship, can't take a citizenship exam. So a lot of times it's those practical assistance issues that bring them in, and then over time can make a relationship and address some of the other issues. So I kind of sort of think about culturally responsive evidence-based mental health care in this sort of way, and I think there's a lot of this sort of pulls together sort of what's happening in the global mental health research world as well. And I think the Twin Cities is a really great place to do global mental health work because we have a lot of resources here that allow us to do things like be culturally responsive. So understanding that culture shapes illness presentation, that you're going to have a lot of heterogeneity. So, for instance, hearing voices may be an experience someone is having. In the Somali culture, this feels abnormal. This is not a normal thing. It may indicate the presence of jinns, which are sort of spirits that cannot be seen, that have sort of come into the body and, in a possession sort of way. And so this is something that's not a normal thing, and people are going to seek out traditional help for this. In the Hmong community, hearing voices, sort of the mild to moderate experience, may indicate some special abilities to bridge the human and the spirit world. So these may be folks who are candidates to become shamans and traditional healers. Very severe and disorganized folks with psychosis are not going to be able to do that kind of role. So hearing voices may mean something different. For American Indians, it may be part of the process of bereavement, hearing the voice of a loved one that's passed. So in this way, I think because of the diversity we have here, we can really kind of get a chance to explore and understand this heterogeneity and how culture shapes illness presentation. And we can really develop a lot of skills in assessing this. And there's some questions you can ask whether you're in mental health or in medicine, seeing folks, internal medicine or family, infectious diseases. Questions like, why do you think you have this problem? What do you think is the reason you have this problem? How do you explain it? It's really interesting to hear that response, how do you explain it to your family and your community? Or what do they think is going on? It's going to get you some more of that sort of cultural context. Are there any religious or spiritual beliefs that help you understand why you have this problem? What help have you sought out so far? And if you were back home, what help would you have sought out for your problem? This can also really help sort of just get at sort of what might be the barriers. So whether it's you're treating someone's diabetes or a mental health problem, it can get at some of the barriers and understanding where they're coming from. And asking those kinds of questions can also get around understanding the stigma and shame. I think in the Somali population, people with mental illness can be very socially isolated. And it's an intense pain of isolation because it's a communal culture, a family-oriented culture. And there's this belief that once someone becomes mentally ill, they never recover. It's like you're either crazy or you're not crazy. The idea that there might be a spectrum, the idea that there may be normal responses of stress. And so there's a lot of fears around seeking out mental health care. And this is where sort of it's like if someone does, it might mean, like they'll be forever stigmatized. That said, you see amazing rallying in the Somali community and taking in relatives who are really ill. And so, there's stigma, and yet there's also, so much, there can be so much family support too. So I think providing some education around our Western approach to understanding mental illness, providing that kind of education can be really helpful. It's not your fault this is happening to you. Let me explain the reasons why this might be happening to you. And that there's hope and possibility that you can, with treatment, recover, live a meaningful, purposeful life. Can be really, really helpful. Models to reduce language and cultural barriers, interpreters, having cultural brokers, these are all things that can be really helpful. Figuring out how to negotiate treatment. There's a lot of medication non-adherence in populations that just don't understand, and so getting at that can be really useful. And then the last couple things I'll say around sort of the work here locally and how it connects to global mental health. One is around, where will I start? Maybe trauma-informed care, which is understanding that most people who have a mental illness have probably experienced some sort of trauma. And having a mental illness itself is a risk factor for trauma because often, there's going to be a response to those people that might feel traumatic. So there's a bidirectional relationship there. So really normalizing can be helpful. This idea of being recovery-oriented is really important. So a goal being to minimize symptoms, to minimize their impact, but also identifying strengths, finding ways to mobilize people's hope. Sometimes that means we're carrying their hope for them early on. And eventually, though, that has to be internalized. Finding purpose, social inclusion, and this is where programs like case management to help identify food, clothing, shelter, and security in that sort of base of the pyramid of needs is so important. And then sort of vocational programs, educational programs, employment programs to allow people to feel like they can be contributing members of their families and communities is really important. I don't know if many of you are aware there are community stabilization programs. There are drop-in centers where people who have mental illness can go where sort of they can have a sense of belonging and some activities and groups and learning that they can do together, clubhouses. So these models really support people in sort of becoming a part again of society, which, given the extent of stigma, is a really important part of thinking about treatment. Integration with primary care, and I'd say across really all health platforms is so important. And this it's kind of it's really everybody, regardless of your area of medicine or what you're doing in public health, mental health issues cut across all these sectors. I mean, so there's really an opportunity, regardless of where you sit, to be thinking about these issues and to be involved. And then the idea of task sharing, which is really important and interesting. I mean, given just the huge lack of resources that we have for mental health care globally, and we deal with it, we struggle with that here. I mean, most people you talk to can't get have to wait for weeks or months to get an appointment with, a psychiatry provider or, and we're here in the Twin Cities, forget about in the rural areas. So thinking creatively about who else can we bring into our care. Here locally, there's a really interesting program going on at Fairview in training imams. We just heard from this group earlier this week at Kook, and maybe some of you have as well. And it's kind of this really interesting program in training imams in mental health, mental illness, sort of a mental health literacy sort of program where 10 imams have been trained over the last couple of years in all different topics in mental health. So that when people come to them, which the majority of people, say in the Somali community, are first going to go talk to their traditional healer, their imam, when they're feeling distress, those folks can support them in making appropriate referrals and letting them know that they support them seeking out mental health care. And there's bidirectional learning there too. I mean, there's ways of healing that may be going on in the traditional healing approach that we could learn a lot from too. So I'm going to wrap up here. In summary, global mental health is one of the most challenging public health issues facing the world. I think it's safe to say that. It's an issue that cuts across so many different areas, and looking at the disability that it creates it's pretty profound. The research and the way global mental health issues are framed are relevant to local challenges in Minnesota and vice versa. I think a lot of times in the U.S., we can learn so much about what people are doing in other parts of the world and bring those lessons home in this bidirectional learning way. And so there's a lot of opportunity to sort of think about what we're doing here, what can be applied abroad, and vice versa. This idea of coupling evidence-based psychiatry and therapy treatments with recovery and rehabilitation. And I think that's sort of the direction things are moving around the world too. And that we have a lot of really excellent local, global, clinical, and public health and policy learning opportunities here in the Twin Cities. Okay, so thank you very much. Thank you, Beth, for the invitation, and to Kook.
We do have time for a few questions. If anybody has questions, I'll try to get to you with a microphone. Otherwise, I'll have Madhuri repeat the question for the recording.
Thank you. That was good fun. How do you think the DSM-5 applies when you're working, internationally with people from other cultures?
Mm-hmm, mm-hmm. It's a great question. I think there's a lot we need to study around that issue because there are so many different presentations of illnesses. I think there's illnesses that are like quite severe, like schizophrenia, obsessive compulsive disorder, that sort of have a similar way that they look in a lot of different parts of the world, and yet the nature of the delusions or the content, say, of someone's psychosis or hallucinations is going to be more culturally specific. I think depression, there's a lot of different ways that presents that doesn't necessarily always get captured in the DSM-5. I think what we need are more studies looking at sort of how applicable are these criteria, how well are we capturing illnesses, and also sort of working from, so there's a cultural adaptation kind of model, and then there's also sort of developing an understanding, sort of working from the ground up of what are the sort of unique illness presentations in a particular part of the world.
feel like I should already know the answer to this, but I have absolutely no idea. Thinking of our refugee populations in particular, do they tend to have higher rates of mental health issues than their similar peers who have stayed closer to the home country, or different rates? Because I can picture having been able to be resettled, maybe they would have less, maybe this is a more select population, or being disconnected from home more, it might actually have a higher percentage. So I'm just curious, and I don't really know the answer.
Yeah. Well, there's really, the little research that's been done around mental health in refugee camp settings, shows high rates. I think in Somalia, it's something like 1 in 3 or every 4 people is thought to have a mental illness. Because that conflict in particular is so long and complex. Are the rates similar? I don't really know if I know an answer to that. I think there's so many stresses to being there and the insecurity around being in the camp, and then people come over and there's a lot of hope that things are going to get better, and then the reality often is it's not for a while, so there's a period of time where mental health symptoms can get a lot worse until there's sort of that opportunity to rebuild one's life. So, it may have to do with sort of where they are in there. I don't know, I'm looking to my Cook colleagues to see if they have any thoughts about that.
I think that's a very honest answer. When I work at Cook too, and I think it all depends on like their history, how they are migrating, and where exactly they are landing, and what kind of social support they are having here. Recently, in last couple of months, I saw a few Somali patients who are in North Minneapolis, and they had bad experiences where they were like hit on the road by some people, and they came to me and they said, oh my gosh, I was thinking I'm coming from a country of war, and I was in this camp, and then I was thinking my life will get better, but it's actually not different. I'm coming here and I'm being hit here also. So I think it just all depends on like what's going on and where they are landing.
Related to the DSM-5 question, thinking about screening in these populations, knowing that a lot of the short questionnaires that we use in primary care are based on DSM criteria. How do you advise primary care and other providers in terms of screening in multicultural settings?
Yeah, that's a great question. Actually, the Department of Health Refugee Health Program is working on a pilot right now of questions. They've developed 5 questions to screen for mental health problems in refugees when they're having their medical examination when they first arrive. And I have them actually in another setting, but basically questions that are asking about. So it's different from the PHQ-9. A lot of the questions are going to focus more on post-traumatic stress, but questions like, do you have difficulties thinking? Are you thinking too much? Do you have problems with thinking too much? Which is a way that a lot of times people will identify worrying. And are there things that you avoid doing because they trigger memories from the past or remind you too much of the past? Are there are you remembering back a lot to what you went through at home? Are you having difficulties with sleep? So there's I could get you those 5 questions. There's a pilot right now. I was hoping before this talk to find out where that pilot stood. There was a work group that I think over the last couple of years had gotten together to put together these questions, and they're looking to see how well these questions might capture in the primary care screening examination. Yeah, I think what the PHQ-9 misses is the trauma piece. And a lot of times those are the symptoms that people are dealing with a lot. So it's a really good question.
I think we have time for one more question. We have our second speaker tonight, Dr. Donald Bannock, talking about global mental health abroad. So Dr. Bannock is an assistant professor of psychiatry at the University of Minnesota and is the interim executive medical director for behavioral health at mHealth. He received his medical degree from the University of New England College of Osteopathic Medicine and a Master of Public Health from A.T. Still University in 2006. He then completed a residency in adult psychiatry in 2010 at Brown University, as well as a postgraduate fellowship in psychoanalysis at the Massachusetts Institute of Psychoanalysis. Prior to joining the faculty here, he fulfilled his National Health Service Corps commitment as a psychiatrist working with primarily low-income Native Hawaiians and Pacific Islanders on the leeward coast of Oahu. Dr. Bannock currently supervises third and fourth year residents in their outpatient clinic, participates in the annual Global Health Case Conference through the Center for Global Health and Social Responsibility, and leads an international elective rotation to Kenya for the University of Minnesota General Psychiatry fourth-year residents and child and adolescent fellows in their second year of training. Dr. Bannock.
Thank you, Beth. Can everyone hear me? Is that good? So it's an absolute honor. I want to compliment what Dr. Shore said, to have mental health be incorporated into the work that you guys are doing. And to have such a group of people here makes me quite proud to have you all as colleagues. So thank you very much. To think about a couple of the questions that were occurring at the end of the last talk, a wise social worker once said to me, there's a difference between folks that come here as immigrants and folks that come here as refugees. And it really, I thought, was a really important point. And I bring that up to start the talk, especially after Dr. Shore's. And I was wondering if people can sort of tell me the difference or what you think might be the difference from a mental health perspective.
Refugees don't really have a choice.
Okay, so refugees don't have a choice. Any other thoughts?
By definition, they're places that have persecution, so higher risk of trauma or just other psychiatric things.
So sort of forced out of their native homeland, where they felt most comfortable. Any other thoughts on that? Dignity. Mm-hmm. It's a really beautiful way, and I'd like to have that be the entree into a case example. So it's winter months. Go ahead. I'm sorry? You live with fear. For immigrants or for refugees? Okay. All right. Thank you. So if I were to give you a patient, a 55-year-old female, it's winter in Minneapolis, so it's quite cold out, quite snowy. I moved here most recently from Hawaii, as Beth had introduced, to the time when we had that coldest weather and that snow. But I saw a lot of people in South Minneapolis with traditional attire on, Somali women, and there was a lot of snow, and it was quite cold, and they had sandals on. If you think about that, and you had to choose, is that person an immigrant or is that person a refugee? Now you can put whatever traditional outfit on that person, but if it was different from what you would think would be the norm for that weather, what would you say? Refugee. And why that's important, I think, for us to sort of bridge Dr. Shore's talk to my talk, is that folks who are immigrants come mentally, we'll say, to the United States years before they physically arrive here. Folks who are refugees are physically here, but mentally they're still back in their home country. And I wish I knew the social worker who shared that with me, but I thought it was profound, and it's really shaped me as I look at global health, cultural psychiatry, where my areas of interest is. So hopefully that will be part of what we're talking about and perhaps generate some questions as we move on. So again, what I would like to do today is talk a little bit about developing an international elective through the Department of Psychiatry abroad, specifically in Kenya. identify some of the social determinants of health through a Kenyan context, recognize influence of the World Health, the WHO, in approaching mental health, and explore some of the academic curriculum. And I'll try to be as timely as possible and leave time at the end for questions. So if we think about here at the University of Minnesota, people may be quite familiar with all the different opportunities we offer our trainees at all different levels. Since I was new, and when I first came here, I didn't really know what those opportunities were. So at an undergraduate level, there's a course called Future Physicians course. I started getting in a conversation with Tricia Todd, who helps facilitate that. And during the third year for undergrads, they have an opportunity to go abroad. Often they're going to India to experience what global health is all about. A couple of those students, actually, I went to their presentation after they came back, and they chose mental health in India, and it was quite fascinating to get into conversation about how mental health is viewed there. For medical students, we have IMIR, which provides opportunities for third year and fourth year medical students to go and study, either do research and or do clinical work abroad. And then we also heard about the Center for Global Health and Social Responsibility. This is a department here at the university that has really tried to take a lot of effort that's happening across the university and try to have it condensed into at least being able to disseminate information about all the global health efforts that faculty are doing, trainees are doing across all the different departments and schools. There is the Global Health Case Conference. I'm curious how many people have heard about that? How many people have participated in that? Okay, I see one person, two people that have participated. So this is the third year that we're doing that. If you have any trainees who might be interested across the University of Minnesota, veterinary school, business school, undergrad school, you can participate. We're about a week prior to the actual case conference. You pair up with a team that's usually interdisciplinary to review a global health issue and then present that as a panel to a group of panel to sort of explore and try to make sense of some of the issues that are happening across the world. And then the Tropical and Travel Medicine Seminar, and I'm delighted to be here today for that. I think this map came up last time. This is really just a snapshot of where all of our activities at the university are, and it's probably not completely comprehensive. So again, upon arriving, let's see if I can get that to stay. What I was interested to know is, in the School of Medicine, how many departments are actually doing global health work? So I sent out a survey to, pardon that going on and off, to the various residencies and fellowships, and received about 31 responses. Let's see if we can. Looks good. Yeah, it draws your attention if it's flashing. It's intentional. So sent out this survey to find out really what is the stretch of global health in our curriculum across residencies and fellowships, and got about 31 responses. And from that, I was interested to know specifically, do you infuse global health into your curriculum, whether that is in face-to-face, whether that's via Moodle websites, whether it's in different types of didactics. And about half of those said they actually did. And then I was interested in how much of this is actually embracing mental health. And surprised, about half of those, so about 6 of those programs actually infused it. And then I was interested to know how much time do these various programs spend on the curriculum for global health. And depending upon family medicine, if there's a track in that, they might have a lot of hours versus other departments, residencies, fellowships that don't. So it ranged for global health curriculum anywhere from 100 to 200 hours, but for mental health, it was only 6 hours that was spent. And guess what department actually had the 6 hours of mental health? Psychiatry. So yes, that was the most robust amount of time, and that's still not a lot of time that was spent. And then I was also interested to figure out how many departments incorporate actual global health opportunities abroad. So to give a backdrop, how many people attended last month's presentation? So there was a heavy emphasis on Kenya, and this was just ironic that I'm giving a presentation to follow up on that. So we had two people that presented on primary care access and HIV in Kenya. I'm going to address more of the mental health piece today. So Kenya has a population of about 45 million people. Kenya is in the eastern horn of Africa, surrounded by Somalia to the east. You have Ethiopia to the north and Sudan. You have Uganda to the west and Lake Victoria. And the talk that was given by, I think, the second-year resident talked about perch HIV prevalency right along the shores of Lake Victoria. And then Tanzania, where I know some people have done some work over the course of the years. Nairobi is the largest city. It has over 3 million people in it. The work that I do is in the 5th largest city, which is Eldoret. So I was pleasantly surprised today to hear the chief resident who actually went to the site where I worked. And the resident from last month actually also worked at the site where what I'm talking about today, where I'm talking about. Eldoret has about 300,000 people. The primary languages are English and Swahili, which actually make it a little bit easier for me as a psychiatrist to practice. Since I don't speak Swahili and I don't speak any of the tribal languages, it was quite helpful to be in this community to work. Per capita income is only about $1,500, and the average lifespan is about 59 years of age. So from refugee camps, from the work that you do, you may have heard that one of the largest refugee camps is located in the eastern part of Kenya. And I bring that up because the population there is about now 350,000 people that reside. Started off in 1991, Dr. Shores had talked about, with just a couple of tents. And now it's almost a city, and within the camp itself, there are multiple camps. You have 52 different school systems. You have 11 police stations. You have hotels. You have driving schools. It's really a generation within a generation that's now formed within this area. Kenya is also known, and I bring this up because of the recent incidents also in Paris, for violence. And I bring that up because it doesn't demonstrate the entire country as what's happening in Paris right now. It doesn't demonstrate all of Paris and what's happening and a specific group of people in Paris. But in 1998, there was a U.S. embassy bombing. In 2013, people may recall at a mall in Westgate in Nairobi itself, there was a terror incident. And then just this past year, actually when I was out in Kenya, there was a violent attack that happened in Garissa University, which was not too far from the refugee camp itself. And I can talk more about that and what that was like if people are interested at the end. But Kenya is also much more than the violence. It has significant religious pluralism. One of the questions that came from in the back of the room is that there are different groups that represent a country. About 83% of Kenya are Christians, about 12% are Muslim, less than 1% are Hindu, and then there's also indigenous religions as well. Lots of ethnic diversity within Kenya. These are just two tribes. We have the Maasai tribe here and the Kalenjin tribe, I believe, to the right. But overall, there's 42 different tribes in Kenya. And if we think about when these borders in Africa were created, they were created not based on ethnic and cultural ties. It was based on colonization that happened. Kenya itself became a British protectorate. I believe it was in 1895. 1920, it became a colony. And then in 1965, it had its independence. Central Kenya has the largest population, which is the Kikuyu population. That's about 22% of the population. Where I work is up in the Upper Rift Valley area, and that has the Kalenjin population, which is about 12% of the population. Lots of diversity within, as I said, you have the city of Nairobi, which has lots of high-rises. It has also one of the largest slums in sub-Saharan Africa as well. but within that you have incredible diversity within the people that are present. I worked in Eldoret, which is a town of 300,000. High-rise is probably about maybe 10 stories, but mostly low-rise buildings. But as you get out just a block or two, you start to have paved roads that turn to dirt roads, which have cows walking down it. And we stayed right there as we walked back and forth from the hospital. We stayed to the right here. Was surprised to find out that Eldoret is actually the sister city of Minneapolis. I did not know that, and that happened in 2000. The University of Minnesota Medical School also has their sister medical school at Moy Teaching and Referral Hospital, which is where I do my work, and I just found that out as well this past year. Kenya is known for its different types of lakes, some of the rural area, rainforest. Wangari Maathai, I don't know if people are familiar with Wangari Maathai. She won the Nobel Peace Prize for some of her work in maintaining the tree population as things were being deforested all across Kenya. She's the first woman who was elected to their parliament as well. Amazing woman, but this is one of the rainforests, the Kakamega rainforest, that we were able to climb to the top of for sunrise. This is just a group that we were with. It's also known for prairies and safaris and the different animals that I worked with that are there. Tea is a big export. Flour is a big export. And then the population that lives in the upper Rift Valley area in Eldoret are some of the world-renowned long-distance runners that often came into our clinic that we worked with. But hospitality, it was some of the most hospitable people that I've ever worked with, and that's from the faculty, from the patients themselves. And here are some of the registrars. So the woman in front of me is Florence. She's a third-year resident registrar. The woman to the right of me is Edith Koba. She's one of the attendings and recently received a Fogarty grant to take a look at mental illness in the outskirts in the communities. And I'll get into that in a second for the World Health Organization and some of their initiatives. To the right of her is Ali. To the right is one of the trainees from Brown. So that's where I did my residency, and I'm still affiliated with Brown as well. So I brought a PGY4, and then the woman in the middle is Jasleen Gill, and she was a second-year child and adolescent fellow who joined. Edmund Dow is to the back to the right, and the registrar has left work about 6 hours early to prepare a meal for us, a traditional meal, which was our send-off before we left a couple days before. Shifting over just to global health in Kenya. This is from the World Health Statistics from 2015. The data itself is looking at the middle column here, the years 2000 to 2012, to see was there any change in the top 10 leading causes of death. And there was no change. It looks slightly like there's a drop down in the leading cause, which is HIV and AIDS, because there's a significant amount of time and effort, resources that are being allocated that way. But there was no statistical change. So the leading cause still of death in Kenya is HIV and AIDS, followed by lower respiratory infections, then diarrhea diseases, malnutrition, birth asphyxia, and birth trauma. A lot of infrastructure, a lot of money is being allocated that way, including over 2 million people that are receiving HIV prophylaxis treatment, 2 million people who are receiving counseling and testing, and significant amount of individuals that are testing positive are actually receiving treatment. This includes women, pregnant women prior to delivery. 16,000 individuals are taking antiretroviral medications, and about 16,000 of those are children. I apologize. I'm not certain what's going on here. If we think about the CDC impact, there's about 5,500 different public health officials that are doing work not only with HIV but malaria and other illnesses in Kenya at any given time.
Thinking.
It's not blinking on the screen.
screen?
No.
Okay. Then it must sadly be a
Oh.
projector.
Looks good.
All right, we'll try it.
All right. We think about taking those World Health Organization statistics, something that Kenya tried to do, and Dr. Shores had talked a little bit about that, is how do we approach the global burden of disease, and how do we, as both the United States, but how does the country of Kenya approach some of their efforts at trying to reduce some of those leading causes of death. And they really thought about this and put together this Vision 2030, which tried to target poverty, looking at education, trying to promote gender equality, reducing child mortality, improving maternal health, reducing infection, ensuring environmental sustainability, and also developing these global partnerships to address. But stigma, we heard a little bit about that, and that's where I'd like to go into next. Stigma for mental health is quite significant. It's the major obstacle in seeking health care and to adhering to prescribed medication. And I'm not just talking about mental health medications. I'm also talking about HIV medications, diabetes medications. If patients aren't taking their mental health medications, they're more likely to not be taking their other medications. There's a lack of education of what mental illness is, the kind of care available, and the negative attitudes towards mental illness that patients in the community have. It's often labeled, we heard at the beginning, cerebral malaria. Ironically, that's how people describe mental illness. They don't want to label it, I have schizophrenia, I have depression, I have trauma. They'll say, they come in, I'm hearing voices, I'm seeing things, and what's your diagnosis? I have cerebral malaria. Because the stigma is so strong, people would much prefer to have that, or syphilis, than they would, and we're talking tertiary syphilis, because of the stigma that's associated. Stigma is so significant that people limit their employment opportunities because of this. People will not get married because of this. Families hide mental health illness because if disclosed, people won't marry. If disclosed after people are married, they will get an annulment because of this, and the government supports that. Have any of you watched the CNN special that came out a while back, about 4 or 5 years ago, called Locked Up and Forgotten? It was a documentary that was done on Mathari, which is one of the largest psychiatric hospitals in Eastern Africa, right in Nairobi itself. And it just brought to highlight some of the conditions of inpatient mental health treatment, which were quite abysmal. And from that, developed a commission on human rights looking specifically at mental health in Kenya. And so, one, if we take a step back, people would often think if we were to identify countries that might have a little bit more resources in sub-Saharan Africa, in Africa, people might think, okay, perhaps South Africa, perhaps Kenya. And they were progressive enough over 25 years ago to have a mental health act, which was implemented. Unfortunately, though, there were no resources that were given to that in order to actually keep people accountable for treating people with dignity. If we think about the actual amount of the budget that was spent on it, it's less than 0.01% of the Kenyan government that goes towards mental health. And of that money, most of it goes to administrative cost. So it doesn't even trickle down to the population itself. So some of the recent pictures that we're seeing are actually done by a photographer by the name of Robin Hammond, who put together a book of images on mental health in sub-Saharan Africa. And in this book, entitled Condemn Mental Health in African Countries in Crisis, in the introduction, he wrote, mistreatment of the mentally ill in Africa was the worst assault on human dignity he had witnessed in 12 years of documenting the effects of war and conflict. I think that's a very profound statement. The gentleman to the left is actually a traditional healer. And so the community often will go to the traditional healer and get herbal medicines prior to maybe making it into treatment with a psychiatrist. If I can just take another step back from what Dr. Shores had talked about, the Fairview Imam Project, which I think is pretty spectacular here in the Minneapolis area, is to get the religious leaders to help destigmatize mental health. One of the things that I follow up with my questions to my patients and the residents that I work with is asking, not only have you talked to your imam, And if they say yes or no, I think a good follow-up question is, do they know you're here today? And for me as a mental health provider, if they say no, they don't know I'm here today, that's pretty telling to me, because they themselves are embarrassed and they're worried about, what if people know that I'm here? What if I take these medications? It's part of that negotiating that Dr. Shores had talked about. How do we work with the population that we're treating to make sure they get effective treatment? So the WHO, I'm quite impressed, in 2013 actually has this as one of their major tasks. And what they put together is this comprehensive mental health action plan entitled 2013-2020 with 4 major goals. These include strengthening effective leadership and governance for medical health, provide comprehensive, integrative, and responsive mental health and social care services in community-based settings, implement strategies for promotion and prevention in mental health, and strengthening information systems, evidence, and research for mental health. And the new directions is really looking at community-based care. I mentioned one of my colleagues out there who's not only staying at the larger city to do her work, but she's actually going out to the community clinics to figure out how do we get this to that level. A big obstacle are resources, physicians, nurses, other providers who can provide a proper assessment of mental health illness in the country itself. So medical school and the program that I worked with in Kenya, just to give you a quick backdrop, after high school, students will go on to medical school, which is about 5 years, followed by a 1-year internship. And they may go out and practice, or they may come on back for a residency. In all of Kenya, there are 2 residencies in psychiatry. Don't forget, for 45 million people. If we look at the number of psychiatrists currently who are certified to be, who have gone through training, there's about 100 psychiatrists, but only 50 about those are practicing psychiatry right now for 45 million people. There are about 400 psychiatric nurses and 30 clinical psychologists. The second residency program, which is what I work with and have been working with and have had the pleasure to help get off the ground in the past 5 years, is now in Eldoret, Kenya itself. The curriculum is a 4-year curriculum compared to University of Nairobi, which has a 3-year residency. University of Nairobi has about 40 residents. The residency in Eldoret has right now 8, so we're doing it slowly, but we have incredibly dedicated residents. And don't forget, these are medical students, again, who have said to their parents, I don't want to be a surgeon, I don't want to be a regular physician, I don't want to be a cardiologist, I want to do mental health. And that is a big, big obstacle, because all of these parents are depending upon their children to be the breadwinner for them, but also it's a societal figure for what they represent in their profession. So they really are bucking a system of stigma, and I applaud them for that. The curriculum is first year is basic sciences for the residency. Second through 4th year is clinical rotations. They do a thesis project. And because they don't have a strong neurology department there or geriatric psychiatry department, there is an exchange where the residents come to Brown for those 2 rotations. And then we're sending our residents over. So it's really, truly a bidirectional. Another thing that Dr. Shores said, I think when we engage in global health, is to make sure it's not a unidirectional, I'm going to these countries, but that bidirectional reciprocity, that we can learn equally from those people that are working with us in that process. AMPATH. So I know a couple of people have heard of AMPATH. Have anybody else heard of AMPATH? It's out of Indiana University. Okay, so AMPATH stands for, it's an academic model of providing access to healthcare, and it's been around for about 25 years. It's a partnership between 3 groups: Moy University School of Medicine, Moy Teaching and Referral Hospital, and then a consortium of academic medical institutions out of the United States and Canada. Originally, the goal was to provide HIV and AIDS treatment, but individuals in Kenya felt that, specifically the tribes that we were working with, felt that we don't have HIV and AIDS here, but we have pneumonia, we have skin cancers, we have all these other illnesses that might be related to HIV. When they started to be treated, they actually said, actually, we have this disease, and they started to be treated for HIV. Since then, we now have a much more robust system where we have OBGYN coming in, pediatrics, psychiatry began about 8 years ago. These are the academic institutions that are part of AMPATH. And I put down question mark for University of Minnesota because we're currently being sponsored in theory by Brown, not financially, and there is a financial investment. So they've given us the opportunity at the university to send over our colleagues, me being the attending on record for their trainees as well. So it's a nice reciprocity we have going right now. Again, these are the trainees there. Prior to going, just to give a little bit of a backdrop, we met with the two trainees, and we did journal club every week to review articles on mental health, other types of illnesses, to prepare them for their experience that they were about to encounter. We also prepared various presentations, talked to colleagues, got their presentations that we could use too, in order to help educate those, both faculty and the med students and the registrars, and really tried to think about what are some of the big issues that might be there. About Moy School of Medicine, it began in 1988. I graduated its first medical students first physicians in 1997. Now it's graduating about 400 students. And it has multiple departments as well as graduate programs in medicine. It's located in Eldoret. Started off in 1917 as just a small cottage hospital, became a district hospital, and now when I say teaching and referral hospital, there are only a couple in all of Kenya. This is one of them. So it's a hub for patients to come from. If you think about that map again, patients are coming up from Tanzania, from Uganda, South Sudan, also Ethiopia and Kenya itself. So people will travel quite far to get to this regional hospital. These were some of the colleagues that I worked with. Dr. Daniel Kinyanjui is the gentleman to the left of me, and then the person to the right is Mr. Sangoli. We can compare him to a clinical officer. A clinical officer might be advanced practice physician, perhaps a nurse practitioner or a certified nurse specialist. And then the person to the far right just joined us for the picture. I have no idea who that individual was. Some of the faculty are down here. Dr. Atwali is the second dean of the medical school. And I think it's interesting because although that stigma is there, they have only had two deans of the medical school. And both deans have been a psychiatrist. This gentleman, if you ever want to read any of his work, he's quite prolific in writing about mental illness in Africa. In Kenya, he is a mover and a shaker. He's been followed by government officials because of the things that he says in a weekly journal, a weekly newspaper article or column that he writes. So this is just the hospital and its setting itself. There are various wards that are connected by canopies because of some of the rainy season. A lot of hospitals in Africa, you have family members who do their laundry. So family members come in and then hang it on the property themselves. Beds are limited. There are often 3 people per bed, one sleeping in each direction, and this is in the medicine surge wards. One sitting at the head of the bed, and patients will rotate just because of the limited resources. And again, this is a big hospital too. 2010, when I was there, this was the psych ward, which consisted of a dirt courtyard. To the right was the bunkhouses where all the patients would stay. In the back was an area where they would eat. I was pleasantly surprised in just going back in April where there was a new facility, which was quite different from what I saw in 2010 for the better. So patients have individual beds, mattresses if they're still there sometimes, depending upon the illness. If patients are psychotic, there's an area where a lot of those patients would actually attack the beds and attack the mattresses. So once they're gone, limited resources, we can't always replenish them as quickly. But again, the conditions were so much improved. 2 wards separated by a wall, men on one side, women on the other side. It was open so patients can come and go. Although there's a gate right here, that was for in the evening, they would lock the gate. But people were able to wander around the campus, the hospital grounds, which I thought was pretty impressive and showed dignity for that. I like that word before, showed dignity for the mental health of this population. Typical staffing included trainees, attending social workers, nurses. The curriculum, I'm just going to throw that briefly up there, consisted of rounds, whether it was rounds with the Kenyan trainees and attendings, or we also had independent rounds with the visiting trainees and attendings. Opportunities to do research, if people wanted to do that. Usually the research project started before they got there because we were only there a month, so difficult to get a study up and running. In the evenings or throughout the day, you could do Swahili lessons. Something interesting, we did something called Fireside Chat on Thursday evenings, which is where all the trainees got together from North America, and discussed an issue. It could have been a mental health issue, a medicine issue. We talked about female genital mutilation and what it was like to be an OB who was asked to perform a revision on that and do other things if there was issues that were going on. It was just powerful conversations as we were all there. This is just the lodging themselves where we stayed. Ward rounds. So this again is the unit. We brought the patients out. That was the registrar, the second-year registrar, with me and one of our trainees. There was a nurse in there, social worker in there. As you can tell, what's missing from the desk? Computer. So there's no computers. It was all paper charts. And there were a lot. Patients were seen about once a week unless asked by their family members for them to be seen again. And primary diagnoses there were schizophrenia and bipolar. And again, at the end, I can talk a little bit more about that. These were the primary medications that were on the formulary. Are people familiar at all with these medications? So we have olanzapine, brand name is Zyprexa. And what kind of medication is that? What kind of class of medication is that? It's an antipsychotic medication. Fluoxetine, brand name is Prozac. Antidepressant. Chlorpromazine is a first-generation antipsychotic. Fluphenazine, first-generation antipsychotic. Carbamazepine, Tegretol, a mood stabilizer. Amitriptyline and diazepam. So most of those patients who had mostly diagnoses of schizophrenia or bipolar would get these medications. Just something interesting is Indiana University is in Indiana. The company that donates a lot of the medication is Eli Lilly, who's also in Indiana. Something that I did not notice in 2010 was something called metabolic syndrome. Going back in 2015, it was pronounced just 5 years later. And again, I would say the major culprit to that is which medication out of all these would be most contributory to the metabolic syndrome? Olanzapine. It really is one of the worst offenders. And to see it in just a 5-year span was a learning opportunity for me. Consult liaison opportunities. So we would go around, see patients on cardiology, internal medicine, child and adolescent units. So here's just a really interesting case. 54-year-old male who presented with confusion, ataxia, auditory hallucinations, and visual hallucinations. And the family reports that this happened because a black bug crossed his path about 3 months ago. What do people make of that? Have you ever heard of such a story? So Dr. Shores had talked a little bit about jinn, genies, possession, witchcraft. They didn't talk about that their loved one drinks Shenga, which is a local brew. It's made out of often contaminated water. To expedite fermentation, they would use jet fuel or embalming fluid. Often would cause neurotoxicity. In this patient, what eventually happened was Wernicke's-Korsakoff. I've never seen Korsakoffs before until I saw this patient. So I want to be mindful of time. It's already 8 o'clock. We had various opportunities to go out to clinics out in the communities. These were regular primary care clinics as well as HIV clinics that we were able to work with some of the nurses to try to educate about provision of mental health treatment and assessment. We also worked directly with the HIV clinic right at the teaching hospital. Just to give you a backdrop, this is the public hospital. Lots of people waiting long hours to be seen. Residents would see about 50 patients in a 4-hour period. Most of the patients were just being seen for follow-up on medication. There was not psychotherapy that was being provided. Limited lab access, I think the chief resident talked about. We don't do labs, so if we're trying to test for metabolic syndrome or have patients on, that's why we're not using lithium as much, why we're not using some of the other medications because that's so costly and because of access. ECT machine to the right was one they used for about 20 years. It broke. The one to the left was donated. Unfortunately, it did not plug into their outlet. So now ECT is not being performed, which if we think about ECT, it's actually quite a cost-effective treatment for catatonic depression, for psychosis, for bipolar mania. So it's quite quick of a response. So fundraising efforts are trying to occur to get that. This was the private comparison hospital that we brought the trainees to. Public cost probably about 5 cents to see a psychiatrist. To be seen in the private, it's about $20 to see a psychiatrist. We demonstrated EMGs with the child and adolescent fellow and the medical students, how they work. And then my favorite highlight of the trip was a home visit, which we've lost that in our training. But if people ever had an opportunity to do a home visit, it's so revealing of where our patients come from, the conditions that they live, how they make sense of their world. And so we discharged an 18-year-old young man, who had bipolar episode, mania with psychosis. And he's actually in the front seat, and I'm right behind him, along with all the medical students in this extended van and trainee. And we drove about 45 minutes on an interstate. Then we drove on a dirt road here for another 20 minutes. Then we parked the car, and then we started walking. And we're walking through the village, and as we were walking through the village, more and more people from the community came out, because the community is not just their immediate family, it's everybody in the community. And we're able to have a family meeting. And so the goal, one of my big goals, is destigmatizing mental health. And so we spent a significant amount of time of how do we go about doing that. So we talked to the family about what was going on. They asked questions. The immediate family, the nuclear family, broke away to talk about their loved one. And then they actually asked to take a picture with all the Mzungus, all the folks that were from away. Lectures that were given back at the house. I had opportunities to work with homeless children who would come to a safe space to get meals, to learn how to toil the soil, to create a job different than what they were finding themselves doing, which is panhandling, and sniffing glue was a big piece there, which then was causing mental health issues later on. Worked at an orphanage there. Worked at a place for individuals with intellectual disabilities. And future opportunities is to not only build upon the work that we were doing within psychiatry in the hospital, but really try to stretch out mental health to the community, to start treating it earlier. The earlier we treat mental illness, the better the prognosis, the easier we can return people back to society so they can go to have educational opportunities, so they can actually work, so they can get married. And that's one of the priorities that we have. Just in conclusion, University of Minnesota is now engaged in the Department of Psychiatry in this bidirectional learning. We're hoping to also see if we can bring people over. Kenya's 2030 goal and their vision incorporates a lot of key issues, but I think the goal of the WHO's Comprehensive Mental Health Action Plan and some of the recent atrocities sort of highlighted by the CNN documentary is really bringing mental health up to the forefront, and I think that they need to be commended on some of the work that's happening there. Just have a couple of journals in case people are interested in mental health at the global level. And then finally, a couple of professional societies. If people are interested, the Society for the Study of Psychiatry and Culture in May 2016 is coming here to Minnesota. Actually, Dr. Shores is part of the planning committee of that. And we just had a Minnesota Psychiatric Society conference on Friday, which dealt with mental health and cultural psychiatry in particular. With that, I'd just like to show you a couple last-minute pictures. This was something I saw on a window there, which I thought was interesting. I want to thank Beth, the seminar, for having Dr. Shores and me here today, my Kenyan colleagues and American colleagues, Ampath Brown University and the University of Minnesota. And these are their hearse there, so farewell and thank you.
Wonderful. Thank you so much, Dr. Banik, Dr. Shores. I think that's all the time we have for today, but thank you, everyone, for coming. Thank you to